Hi everyone, and welcome to yet another video. This is probably one of the most important topics to our dental community. It's poorly understood, it's poorly practiced, and usually it leads to unnecessary root canal treatments than actually needed. It took me 2 years of reading to completely understand this subject, so I'm going to summarize it in this video today. I know how confusing it is to choose between direct pulp cap, indirect pulp cap, stepwise excavation, partial pulpectomy, full pulpectomy. I know that there are so many options that probably it's very difficult to choose between when you are in the clinic. So this is a very big subject, so you really have to be patient with me today. And I promise you, if you listen carefully, you will master this subject. I'm going to divide this subject into number 1, we'll talk about the caries as a disease, and then we'll jump into the pulp reaction to caries. After that, we'll talk about the different treatment options. We'll read some papers on each treatment option, and at the end I'm going to summarize everything. But you really have to follow all the video from the beginning in order to understand the summary. So I'll see you soon. This part I'm going to focus on caries. Fact number 1, caries is not gangrene. The progression of caries is dynamic. So in order for caries to progress, it has to be living in a specific environment with multiple factors. Sometimes we have to go back to the basics to understand things properly. I don't know about you, but this is from the first year microbiology. If you remember, these 4 factors have to be present together in order for caries to be active. So as you can see, there is a time, teeth, and bacteria, as well as substrate, which is basically sugar. So if we take just one factor from this equation, we're actually going to force the caries to arrest. Typically, in any lesion, it will go through cycles of active disease and inactive disease, and it depends on how good the patients with oral hygiene. Sometimes the progression of caries is very slow, and sometimes it's really fast. When you see a lesion that dark, I can bet and guarantee that this is a vital tooth, because it seems that it's extremely dark, which indicates that it's a vital tooth. So darker in shade, hard to probe, usually are positive to cold, which means that the tooth is vital. When you see a lesion that is lighter in shade, brownish or yellowish, it's quite the opposite. Lighter in shade and soft to probe usually will be negative to cold, which indicates that the caries actually reach the pulp and caused pulp necrosis. Do not underestimate the pulp capacity of healing. There are 3 main mechanisms the pulp can do to protect itself. First, it will actually cause dental sclerosis. These dentinal tubules underneath the caries will actually decrease the permeability of these dentinal tubules, and instead of 100% permeable, it's going to be only 20% permeable. Decreasing the permeability will actually reduce the amount of bacteria that goes into the pulp. Number 2, tertiary dentin. As you can see, the pulp will actually protect itself by laying down some dentin to be away from the caries lesion. Number 3, immune cells. Any bacteria actually can penetrate all the way and goes to the pulp will actually be eliminated by the immune cells. Now it's important to understand that the pulp can and will protect itself only if the caries progression is slow. If it's fast, it will not have enough time to lay down tertiary dentin, and it will cause necrosis. So how can we tell? Number 1, from the color, the lesion, and number 2, we should perform a cold test just to make sure the tooth is vital. Now there are 2 responses that you can get from the cold test. So when you perform a cold, you look at 2 things: duration and the intensity. Usually we don't care about the intensity because this is very subjective to the patient. The intensity, however, is extremely important. You monitor how many seconds the response can last for. If it's a couple of seconds, up to 5 to 10 seconds, that's fine. If it's lingering for at least 30 seconds or more, then there is irreversible pulpitis. If there are no response, that means it's pulp necrosis. So if you have a tooth that is lingering, or if there is no response, then don't worry about vital pulp therapy. Just go ahead and do the pulpectomy, because that tooth will need a root canal treatment. I just realized that I said intensity is more important than duration. It's the opposite. The duration is far more important than intensity. If you heard about the strangulation theory, but basically what it means that when there is an inflammation in the pulp, it will go all the way to the apex, and then because there will be elevated blood pressure, it's actually going to strangle itself, and then the pulp will be necrotized. But there are many studies that actually showed that this is not true, because most of the histological and physiological studies have shown that the inflammation is usually only around the pulp exposure, and the rest of the pulp is fine, and there are no elevated blood pressure and no inflammation. The question is, when the pulp is inflamed, can actually the pulp heal after inflammation or not? I'll show you a study. Healing capacity of human and monkey dental pulps following experimentally induced pulpitis. So they induced pulpitis. What they did, they put bacteria next to the pulp, and they wanted to see if the inflammation will go after sometimes. And they found that the inflammation will be at most after 32 hours. As you can see, this is the dental tubules, this is the inflammatory cells, as you can see, huge. But after 30 days, complete removal of the bacteria, and the immune cells will go back to normal. As you can see, this is the tertiary dentin, means healing. And what they showed in this study is that the pulp can actually resolve after inflammation. This is a graph to show you how close can you be from the pulp and not have inflammation. So you can be as close as 0.7 millimeter from the pulp. If you're closer, you're going to actually cause inflammation and pathology. So underneath caries, you can be as close to the pulp as 0.75 millimeter. Why? Because as we discussed before, underneath caries you have sclerotic dentin and reduced permeability. So basically the dentin underneath caries is very protective. But underneath fresh dentin you have to be away from the pulp at least 2 millimeter, because the permeability is 100%, and there are just highways all the way to the pulp. So with fresh dentin you have to be careful. Underneath caries, you really don't have to worry about it too much. Let me show you an example. So here, this sclerotic dentin is very protective. You can be as close as 0.5 or 0.75. But when we remove caries, we really don't just remove the caries. We usually make a box, and we're going to expose fresh dentin. So you really have to be careful when you deal with fresh dentin, because you have to at least maintain a good 2 millimeter remaining dentin thickness. Welcome to the second part of deep caries management, and today we'll focus on mainly clinical situations. When we talk about deep caries management, we mean caries that is at least within the 2/3 of dentin. The problem with these lesions is it has a very high risk of pulp exposures. The percentage of pulp exposure in these cases is at least 30 to 40%. So if you see 10 cases of these lesions, you will at least have a pulp exposure in at least 3 to 4 cases out of 10. So it's a pretty high number. I'm sure that you have experienced this situation before. How can we reduce the risk of pulp exposure? We'll talk about that later, but we'll focus now on dental materials. Now, the majority of dental materials are toxic to the dental pulp. So composites causes dilation to the dental pulp, and if you put it next to the pulp, you will cause severe sensitivity and the pulp will end up being necrotized. Ionomer, however, is milder, but it's still toxic to the pulp. So these two materials should be away from the pulp at least 2 millimeters, and if it's closer to the pulp, then you have to think of other materials such as bioceramic or MTA. So if you think that the remaining dentin thickness is more than 2 millimeters, then leakage is not significant. Glass ionomer should be used as a base, and then you can just put any restoration. However, if the remaining dentin thickness is less than 2 millimeters, then leakage is significant, and you should use at least 2 millimeters of thick MTA or bioceramic, and then you can do the final restoration. When you drill dentin, you should think about it as a living organism. You have to avoid using acid etch, avoid using bonding agents right on fresh dentin, because that will cause severe sensitivity. And you should consider using a liner such as glass ionomer to fill the majority of the dentin, and then you can place your composite. Now, the question is, can we leave caries behind? You can absolutely leave it behind, but you have to do it the correct way. So how did I know about that? Well, I don't know if you heard about stepwise excavation, but this is a very famous procedure that was developed in Denmark. So let me show you a couple of cases, and then we'll talk about why is it okay to actually leave caries behind. Stepwise excavation is one of these procedures that is developed to reduce the pulp exposure. So the pulp exposure in this procedure is 19% compared to 30 or 40%. Typically, you remove the peripheral caries from all around the cavity, and then you leave just the caries around the pulp. And then you put a calcium hydroxide, and then you fill it. You leave it for at least 6 to 9 months, and then you open it again. What we learned from these procedures is when you open the cavity 6 or 9 months later, we found out that most of these caries actually they arrest. They become harder and they become darker, which indicates arrested caries. Now the question is, why do we have to open it again and remove the remaining caries if that lesion actually have arrested? This is a very famous study that compared partial caries removal and stepwise excavation, and they had a 3 years follow-up. So they had 152 cases of partial caries removal and 147 cases of stepwise excavation. The result of this study have showed that the success of partial caries removal is 91% and the stepwise excavation is 69%. So what they showed is that we really don't have to reopen the cavity again and remove the remaining caries, because if we do that, we will force the lesion to arrest, which is something that we talked about yesterday, that if we change the environment of caries, you actually can force the lesion to arrest. So typically, when I see a deep caries and the tooth is vital and there is no history of pain, then I'm going to remove all the caries on the peripheral part. I'm going to leave the caries in the middle that is close to the pulp, even if it's soft. And then I'm going to cover it with glass ionomer and then composite. Now I have to explain that to the patient, because I don't want this patient to go to another dentist and the other dentist might think that I'm stupid because I didn't do the right, because I didn't remove all the caries. Because not everybody understand this procedure. What's good about this procedure? It's cheap, it's easy to do. You don't really need a rubber dam. You don't need fancy, expensive materials to pulp cap the tooth. So this is a good option, and we'll talk about the other options in a minute. If you have a personal issue with caries and you really wanted to remove it, that's fine. We have another solution for you. Direct pulp cap is a famous procedure that can be used to preserve the vitality of the pulp. Traditionally, we used to do direct pulp caps on teeth that have been accidentally exposed or due to trauma. But recently, we started to see a very good results even with caries exposed pulps. This is a famous study by Bogan. At that time, he did a series of cases, and he had a 98% success. And the secret to his success is actually the way he treated the cases. So what he did, he actually places a very thick MTA material to all the floor. He doesn't even leave any dentinal tubules on the side to communicate with the pulp and jeopardize the survivability of the pulp. And with this technique, I found also is very promising if you seal all the dentin underneath the caries. At the beginning, they were questioning his study because it was a case series, but there is a recent study that actually confirmed this, which I'm going to show you in a minute. This is another study that was recently published, a randomized clinical trial to compare MTA to calcium hydroxide, and what they showed that after 3 years, the success of MTA is 85% compared to 52% to calcium hydroxide. And this is probably one of the first papers that had a high quality design that showed that MTA is actually can be used even in cariously exposed pulps. What's interesting also in this study is that they also did these cases on adults up to 55 years old. So this is something new because the majority of these cases would be used on children. The other option after direct pulp cap would be partial pulpotomy, and basically what that means is that when you remove the caries, you actually go inside the pulp and remove part of the pulp, because they assume that maybe there is a micro abscess next to the caries lesion. How successful? It's very high success. It has a very high success rate if used the correct way. Next would be full pulpotomy, and by that I mean to remove all the pulp and then just leave the vital tissue inside each root. How successful is that? Very high success rate. There's a guy who's called Witherspoon who actually did this the first time, and what he showed is that even if the tooth has irreversible pulpitis, symptomatic, they actually can get a pain relief within 24 hours. And what's good about this, it actually positions the pulp below the CAG. So when the patient drinks something cold or hot, they don't actually feel it. And for that reason, it worked. In order to do either direct pulp cap or partial pulpotomy or full pulpotomy, you need to have a good isolation, a rubber dam. You also need to buy expensive materials such as MTA or bioceramic, and then you have to do it carefully. So it's much more expensive. So what's my favorite procedure to do on these cases? It's actually partial caries removal. The reason that I like partial caries removal or indirect pulp cap is because I don't have to worry about pulp exposures. I don't have to worry about isolation. What I need is just a glass enamel and composite, and that's it. The patient experience would be much better. And when I need a root canal treatment, I can do it anytime. It's not a big problem. So this is my favorite, and let me know what you think of this. and I'll see you soon. And send me questions if you have any. And good night.